Hello, everyone. My name is Katia Coley. I am a family nurse practitioner and I'm also a psychiatric nurse practitioner. And today we are going to talk about mental health disorders from a primary care perspective. First, I want to say thank you to Dr. Janice Williams for allowing me the opportunity to provide this lecture. Our objectives for today are uh, to define mood, anxiety, substance use according to the DSM-5 criteria. Then we will go on to clinical presentation, identifying clinical presentation of the patients with mood, anxiety, and substance use disorders. Identify the difference in clinical presentations of each of these patients and demonstrate the ability to perform an appropriate mental health screening on patient with mood, anxiety, and substance use disorders. We will go on and discuss appropriate patient and family education regarding mood, anxiety, and substance use disorders, discuss and identify the importance and components of health promotion for patients with mood, anxiety, and substance use disorders. And last, we will demonstrate how to perform a mental health assessment and plan on patients with mood, anxiety, and substance use disorders by using case scenarios and role playing. Mental health disorders, we will discuss three type in this presentation. First one will be mood. We'll discuss depression, bipolar disorder, seasonal affective disorder. Anxiety, we'll talk about generalized anxiety disorder, panic disorder, obsessive compulsive disorder. And substance disorders, we'll talk about the sedative, the stimulants, the the psychotomimetic and hallucinogens, inhalants, and of course injectables as well. So one suggested approach to the when you're in primary care is that you kind of need to understand the symptoms that may be suggesting any psychological or physiological or psychosocial where they're coming from and the cause of it. So you always want to rule out any physiological or medication cause for suggesting that the patient is having these symptoms. Always consider domestic violence, also consider substance use, also try to use the mnemonic BAVE and heads to kind of help you to understand what the cause or what could possibly be the reason why it's a person is experiencing the symptoms they are experiencing. Also screen for suicide risk, depression, anxiety, and bipolar. And if you find anything that is positive, then it'll be good to either continue to evaluate that patient or refer them to a mental health professional to help to diagnose them or assist them. Mood disorders. So there are several different type of mood disorder that you may encounter in primary care. Patients usually come feeling sad, feeling empty, feeling irritable. Sometimes they have somatic symptoms, cognitive changes. So that's usually what they will come up, and those can lead to pretty much these type of diagnosis as a major depressive disorder, persistent depressive disorder, which is dysthymia, premenstrual dysphoric disorder, substance medication-induced depression, depression due to another medical disorder, unspecified depressive disorder. The three other type of mood that we see very much in primary care are major depressive disorder, bipolar 1, and bipolar 2. So in major depressive disorder, the one thing that you will notice is that that person has pervasive symptoms that are affecting their mood, affecting their physical health, that affects their work and their relationship. Then for bipolar, that person will literally have a manic episode. We'll go more into it and what that looks like. And then in bipolar 2, they will have either experienced past or currently experiencing a hypomanic episode, and sometimes that is also with a major depressive episode. Epidemiology of major depression in adults. In 2017, SEMSA had decided that, I mean, not decided, excuse me, had suggested that that um, pretty much you will see 13.1% of depression is seen between the age of 18 to 25. It is across the board as far as racial and ethnicity goes. More women, females are more prone to having major depressive episodes than male are, and of course also that about 64% have severe impairment, and only about 36% of people have do not have severe impairment. Also, it goes on to show the what is major depression in adolescent, which is another group that you will see doing primary care as well. Notice that it occurs more during the teens age. You see more of it happening, and COVID has worsened that even more this past 2 years. So there is a rise on depression in adolescent. We'll talk more about that. So, in order to diagnose someone with major depressive disorder, there are a couple of things, criteria that they have to meet. And among these 9 criteria, at least 5 or more of them must be present for at least a period of 2 weeks. And at least one of those symptoms need to be either depressed mood or loss of interest or pleasure in doing things. So when a patient present, you want to ask questions that will help you to make sure that they meet these criteria in order for them to receive that diagnosis of major depressive disorder. Manic episode. In order to be diagnosed with a manic episode or be called bipolar mania, you have to have at least persistently had elevated, expensive, or irritable mood, and that has to last at least a week, and it has to present itself almost nearly every day or nearly every day. And sometimes it may require hospitalization. Um, of course, out of these criteria listed here, you have to have at least 3 or more of the following of them, and definitely 4 if all the patient is saying that they've been feeling irritable. You have to have at least 4 of these criteria being met. For hypomanic episode, it's a little bit lesser time. Patients still present with elevated, sometimes irritable mood as well. And sometimes they have high energy, sometimes they have increase in activity, and that lasts about 4 consecutive days. And sometimes it's only present every day and not, but at least nearly every day it should be present. Again, they have to have at least 3 or more of those criteria and 4 of them if they are only presenting with irritable mood. When it comes to hypomanic, you also want to make sure that the change of mood and function as well is being observed by others. Usually a family member will say something, and sometimes potentially could also have psychotic features where that may require hospitalization to help the patient to start to feel better. The physiology of major depressive disorder is that it could be genetic, it could be stress, it could be that there are some biogenetic and receptor hypothesis and the neurobiological hypothesis as well. Risk factors are to first degree relative history, stressful situations, unemployment, marital discord, history of sexual abuse or trauma, drug and alcohol use, death in the family, or any major life changes. So one of the ways to kind of identify the symptoms of bipolar disorder is the mnemonic dig fast. Your patient will experience D for distractibility, I for indiscretion, meaning excessive involvement in pleasurable activities. They will have grandiosity, flight of ideas. They have activity increase, sleep deficit, meaning they can go on little sleep 3 hours and feel fully energized and ready to go. And they tend to be very talkative and have almost like a pressured speech. The clinical presentation when it comes to depressive disorders is that they come in, a patient will present with symptoms, they're not always present, excuse me, with symptoms of depressive symptoms. They don't always come with that. Sometimes they come with somatic concern, like, oh, I have a headache or my stomach hurt. And for children, sometimes it's irritability, and sometimes it could be behavior or anger outbursts that will present itself. And sometimes with adults, they sometimes they will say that they've been feeling down, they're having trouble getting out of bed, and some type of hopelessness feeling that they have. So in older adults, mostly it will be somatic. They start having pain, back pain, headache, stomach pain. That really physiologically, there's no real reason for it. When it comes to bipolar disorder, or the patients sometimes they will present themselves after either after they've had an acute mania, and typically they have history of depression as well in the past. Sometimes they have psychotic features like delusion, hallucination. They may experience that and not sure what to do with it at that time, and that's why they come into primary care. So the physical symptoms that usually are reported and may prompt you to look into more in primary care is that the patients sometimes look unkept. Sometimes they complain of having loss of libido, or they complain of amenorrhea, or they're having trouble sleeping, trouble staying asleep, trouble falling asleep, headaches. Sometimes they talk about they feel like a tightness in their chest. Sometimes it's they're having skin picking, or they're having like aches and pains that are despite looking into different diagnostic does not make necessarily any sense. The other thing that happened that they complain about is like, oh, they either change in appetite. Sometimes you see a decrease in appetite or a decrease in weight, or increase in appetite and an increase in weight. Sometimes they'll say that I have diarrhea, a change in the bowel function. Some people say that they have dry mouth. Some people complain of heart palpitation or their heart racing is what they'll say. And sometimes they talk about indigestion, and sometimes I just feel like I just feel slow. Like I just feel like I can't really complete everything I need to complete throughout the day. The psychological symptoms that you will see with these patients is that they will sometimes have their thoughts are slow and difficult. They have trouble concentrating. So those are the keywords you want to hear for. They have thoughts sometimes like really morbid thoughts of suicide, that they want to hurt themselves, or with adolescents, sometimes you'll hear of wanting to harm themselves as well, cutting. So those are the things that you will hear, and then feel sad or feeling low or feel flat or feeling meh. Sometimes they will express it as that. And sometimes people are feeling kind of fed up or indecisive, and sometimes that you hear that I don't really have interest. I used to enjoy going for walks, and now I don't even feel like doing that anymore. I used to enjoy reading. I don't want to do that anymore. Um, so just pretty much a lack of interest in life, a lack of interest on things they used to enjoy, and sometimes their speech is very negative. They have negative outlook on life. So those things should prompt you for further assessment. So whenever you meet a patient in primary care, you always want to that have shared these previous symptoms with you. You always want to assess them for suicide ideation, if they've had any prior suicide attempt, if they're having any psychosis, any hearing voices or seeing things that others are not seeing. And if these ongoing depressive episodes have been going for more than 2 years, you want to know about that. You also want to make sure that you are these symptoms are when they are occurring. Did they happen? When did they start? Was it between the age of 20 and 50? And if they have anything that relieved those symptoms in between. And also you want to assess that if they've had persistent symptoms of depression and for how long they've had these symptoms for. So key questions during your mental health assessment that you want to ask is always want to ask about personal or family history of mental illness. You also want to ask about family history of autism. You want to ask about if they have, in the past 2 weeks, have you ever felt down, depressed, or hopeless? In the past 2 weeks, have you had any interest, a little interest or pleasure in doing your daily activities? Like something as simple as taking a shower. Some people find it really hard to do when they're feeling down. And then they're asking them, do you tend to be anxious or nervous person? And you can even ask questions like, have you had periods of feeling so happy and energetic, and then later on you're feeling that you are really feeling very happy and talking too fast, and that you are too hyper type of feeling. Those kind of things are the questions that you need to ask to kind of get an idea. When you asking those questions, one of the screening questions you can use is is another mnemonic again, is SIGCAPS. You can use that as well to kind of help you gather all the information that you need from that patient. Change in sleep, change loss of interest, um, guilt, loss of energy, any trouble concentrating, any change in appetite, any psychomotor inactivity, or any thoughts of death or suicide. These, when you hear these symptoms, or if they're express any of those, that will kind of help you understand more of what type of diagnosis that they're potentially could be having. Physical exam and diagnostic. So there aren't there are specific questions you should be asking to determine if the patient has been feeling irritable or depressed. Then you also want to make sure you ask about lifestyle. What medication are they taking? Are they sleeping too much? Did they gain more weight? Then you want to ask them the diagnostic by the interview. So that's the key point where you are. It is all subjective, so you want to ask good questions so you can get as much information. Then labs do help to kind of rule out any physiological etiologies. So definitely making sure you're checking their endocrine, as in like thyroid, checking in to make sure there's no vitamin D is okay. B12, I'll go over that list a little more later in this lecture. Then sometimes they do some head imaging, sometimes some cardiac testing to kind of just rule out any other physiological symptoms that could be potentially be there. And definitely, again, family history of depression. Screening tools that we use there are several, but the most used in primary care are the PHQ-2 and the PHQ-9 screening. Some people do use the Beck depression inventory, but the mainstay or the geriatric depression scale also is used in primary care, but the one that you'll see most of the time is the PHQ-9. It looks like this, and pretty much it will give you a score, and based on that score you will kind of have an idea whether this patient is having mild symptoms, moderate symptoms, or severe symptoms, and that will then help to kind of determine your diagnosis, and also help to kind of determine what will be your next step as far as treatment plan. Labs, as I was talking earlier about, you need to do a metabolic panel. Always want to check liver and kidney functions as well. Complete blood count. Want to check the thyroid. Some people do a 24-hour free cortisol, but you want to do a vitamin B12, folic acid, making sure that the patient is not anemic as well, and also check the urinalysis. You may want to do that to check also maybe even a drug test as well for the urinalysis. Make sure that they don't have any, especially in the elderlies, that they don't have any UTI as well. Check the vitamin D, and sometimes checking a pregnancy test as well, especially if you have thoughts of starting the patient on medication. Always want to check that for someone that is not using any protection for their sexual activities. Differential diagnosis, as far as there could potentially be other cause of it, such as medication. Some of the medication that we've seen have caused some symptoms related to depressive symptoms are Accutane, Antabuse, anticonvulsants, the Parkinsonian medications, antivirals as well, benzodiazepine, your beta adrenergic blockers, your calcium channel blockers, estrogen, fluoroquinolones, antibiotic, narcotics, statins. And then there are certain medical conditions as well that can potentially have the same depressive symptoms as well, which are viral infection, hypothyroidism, diabetes, cancer, having a CVA, myocardial infarction, hypoparathyroidism, anemia, infection, electrolyte disturbance, respiratory disease, and dysthymia. So it is very important to obtain those labs and also clear the patient from physiological symptoms to make sure that potentially that any of these medications or medical condition are not the cause of the patient's symptoms that they are experiencing. Management. So again, safety first at all time. Assess the patient for suicidal ideation or suicidal thoughts to make sure that they are safe. And then the next thing you want to pharmacotherapy is the other things that we use, which are for depression, we use the SSRIs and the SNRIs. And when it comes, and we have to kind of monitor the patient 4 to 6 weeks after starting the medication to make sure that they're doing okay. And when it comes to bipolar disorder, sometimes they are started on mood stabilizers or antipsychotics as well. As far as non-pharmacotherapy goes, there is therapy. Psychotherapy is a very good mainstay, and it really can treat, especially when it's mild depression, or it can really help treat it. Cognitive behavior therapy can help with the negative thoughts, and also doing interpersonal therapy as well has been shown. The research shows that it has been very effective in treating depression. Nutrition, making sure that they're eating a well-balanced, healthy diet. Using bright light therapy is another one. ECT if other medication and other treatment have not been successful, and vagus nervous stimulation as well, and that was approved back in 2005 as well to help with management. So treatment phases, the acute phase is between 6 to 12 weeks, and then you want to continue it for 4 to 9 months. And then after that, kind of a maintenance that happens thereafter. So because these medication can cause withdrawal, so it's always good to taper them down. And depending on the medication, you'll probably have to taper it about 25% every single week and kind of help. Always make sure you share that with your patients, otherwise they can have some really bad withdrawal symptoms that they should not abruptly discontinue a medication, but that they need to be tapered slowly on it. One of the biggest questions that you'll get is, do I have to be on this medicine for the rest of my life? That we don't know the answer to, but what we do know is that in order for the medication to truly be helpful, you need to be at least on it for a year. The next thing that can also you need to think about as well when working in primary care is the difference between emergent intervention and urgent intervention. So emergent interventions are needed as soon as possible, especially when the patient is talking about harming themselves or have profoundly impaired the depression has impaired their symptoms to the point where they cannot really function, or they're experiencing withdrawal symptoms, or they're experiencing lithium toxicity, then that is an emergent intervention, and sometimes it requires hospitalization. Urgent intervention are needed within a week or so, which has to do with making sure if it's someone that have high risk for suicide, but yet not feeling safe, or if they have other psychiatric comorbidities like substance use disorders as well. So you also want to make sure you got to get them help as soon as possible too. Then you want to follow up usually as needed within a month. So for like recurrent symptoms, to kind of make sure that the initial treatment is actually working. So a month later, it's usually a good time to kind of check in. make sure that they're not having any side effects and that they're actually tolerating medication and that it's effective for them. Um, Patient and family education. So always want to talk about adherence, making sure you're taking the medication every day as it is prescribed to be taken, and that they understand that the treatment duration could be 6 months, 9 months, sometimes 12 months or longer, depending on what symptoms they are experiencing. Always encourage both the patient and the family on a healthy diet and making sure they are sleeping at least 6 to 8 hours at night, exercising, whether it be just walking for 20 minutes every single day, but that they go out because that will help their mental health as well. And then always discuss the medication side effects. Most importantly, the most common ones. You will also want to discuss those with the patient and the family members so that they can have awareness of what to expect while they are taking this medication. So talking about side effects, these are the medications that are mostly prescribed for depression. And as you can see, there have almost every one of them have side effects. Not almost, all of them have different side effects. But as you can see, most of the SSRI have the headache, diarrhea, dry mouth, sweating, dizziness. So potentially you want to share this with the patient so that way when they're experiencing these side effects, they will know and be able to alert you so that you can know and know what to do to help them. Um, the VA NDOD has exact clinical practice guidelines on how to take care of patients with major depression, bipolar, PTSD, and substance disorder. Anxiety disorders. Anxiety disorders are we're going to talk about them too. There are several different anxiety disorders. In that group, about 28% of people would experience some type of anxiety, and the type of anxiety are some people have separation anxiety, some people have generalized anxiety, some people have anxiety due to a medical condition, some have substance induced anxiety, some have agoraphobia, some have panic disorders, phobias like social anxiety and selective mutism as well. First, we're going to talk about, again, most common that you will see in primary care, which is generalized anxiety disorder. So in order to meet the criteria for the DSM-5, you have to have at least experienced this anxiety for the past 6 months, for at least 6 months or more, and that it is occurring and interfering sometime with your activities, just as school or work. And you need to have you need to have at least 3 or more of those symptoms with and experiencing it for at least 6 months. So again, the symptoms that you will hear patients feeling restless, feeling on edge, feeling easily fatigued, having trouble focusing, concentrating, and mind going blank. And in children or adolescents, you will hear irritability. Some people complain of muscle tension, and some people will complain of having trouble sleeping and feeling restless and waking up, or if they do sleep, they wake up the next day feeling just as tired as when they went to sleep. So those are the symptoms that you will hear the patients will express that they are experiencing. So on the umbrella of, anxiety pathophysiology, sometimes it has to do with the cortical part of the brain and the subcortical part of the brain. And as you can see here on this chart, the different way that it is, the different path of anxiety and how it is affected. Risk factors for anxiety. Of course, genetics. Sometimes it's also childhood trauma or childhood abuse. Sometimes it also can stem from excessive use of substances. Clinical presentation. So sometimes anxiety can present itself alongside other psychiatric illnesses. But a lot of time people come in primary care complaining of physical symptoms, headaches, stomach pains, abdominal pain. Sometimes they have nausea, vomiting. Sometimes it's diarrhea. Sometimes it's backache. And those somatic symptoms, sometimes that's why we'll kind of prompt you to kind of also check if there's any other anxiety type of things going on. They will tell you they feel restless or feel on edge. Once they start to explain these symptoms, and sometimes they don't use these exact words, they just may feel like, I'm having a lot of trouble sleeping. So listen really well, and the patient will kind of help guide you as to what is going on and what they are experiencing. So again, the physical symptoms that comes in primary care are change in appetite, change in bowel function, dry mouth, palpitation or tachycardia, chest pain, nausea, vomiting, burping, increased muscle tension or tremor or restlessness, loss in libido, increase in menstrual flow, sleep disturbance, and of course the tightness in their chest. Some people will complain of headaches as well. Psychological symptoms, you will hear a preoccupation with ill health. Sometimes they have poor concentration. These are the keywords that you will hear when when a patient is speaking. They will say that they feel helpless. They feel tired or fatigued all the time. They're having bizarre thoughts and they're wanting to run away from fear or from a fear situation, irritability, restlessness, and sometimes they will say, thoughts of insecurity. I don't feel safe at home, or thoughts of inferiority. I don't feel like I'm the best at what I do, or the best at work, or I'm not the best student. A lot of sometimes negative thoughts about themselves. Assessment, you also always want to assess for potential physical injuries. You also want to make sure that the chest pain you rule out that it's not something physiological, as in them having a heart attack. Also, when they're complaining of shortness of breath or dizziness, you want to follow up through and always rule out physiological. Then the GI symptoms as well, and then you just kind of refer as needed based on what you have gathered during your assessment. Key assessment questions to ask is for during the past 2 weeks, how much have you been bothered by the following? Feeling nervous, anxious, frightened, worried, feeling panic or being frightened, avoiding situations that make you anxious. Those are the questions you want to ask when a patient potentially come in complaining of physiological or somatic symptoms, so that you can rule out between the physiological symptoms or versus anxiety. This is a decision tree as far as anxiety goes. So one of the things that you can see on the top is that people have significant anxiety related to their symptoms. And then whether it's moderate or severe depression, then you will treat the depression. If if they have a history of trauma, then you want to check them for PTSD. If they have obsessions or compulsions, then you want to check them for OCD. If they talk about like they have uncontrollable worrying about several different areas or several different things, then you want to check them for generalized anxiety. If they talk about they're having intermittent panic attack or anxiety attacks, you want to check to see whether they're having social phobias or social anxiety, and you want to be very also check about the phobias and check for panic disorder as well. The most common used screening tool in primary care is the GAD-7. It is used to kind of help is provided to the patient to kind of help them to understand, to fill out as the questionnaire to know what symptoms they are experiencing. There is the PHQ SADS or SADS. It's a combine of the PHQ-9 with the GAD-7 that is also used at times. Clinical management. So one of the mainstay of using for anxiety is again pharmacotherapy, using the SSRI, your selective serotonin reuptake, or using the norepinephrine reuptake, your SNRIs, benzodiazepine, buspirone, your TCAs as well, beta blockers, and anti-anxiety medicine as well. Again, non-pharmacotherapy can help and has successfully treated anxiety, especially mild to moderate anxiety, psychotherapy, cognitive behavioral therapy, support group, stress management, exercise, mindfulness, relaxation techniques, and go on and on to kind of help with managing anxiety. One of the first line for pharmacotherapy treatment is using venlafaxine, extended release, or duloxetine as well. Those are approved by the FDA to use. Paroxetine, also known as Paxil, and escitalopram, also known as Lexapro, is used, and those are the dosage that you can start. When it comes to medication, I must say, always start low and go slow, to make sure that you are keeping an eye on the side effects, and also to make sure that the patient tolerates the medicine well. Not FDA approved, but it's continued to be used and has helped many, is sertraline, also known as Zoloft, and fluoxetine, also known as Prozac. So those medications are being used to help, but not necessarily are FDA approved for anxiety, but have been shown to help patients as well. Second line of pharmacotherapy treatment that is used and approved by the FDA are the benzodiazepine. A lot of people are afraid sometimes to use them because they can they have addictive properties to them. However, they do help, especially patients that are experiencing panic attacks, to help to minimize those symptoms. Sometimes they are used as a bridge while we wait for the SSRI or SNRIs to take effect, to kind of help relieve the symptoms depending on how severe the symptoms are used. The key thing is to always share with the patient that they are not going to be on this for long term. Is a temporary use of it is what is recommended to use, and not to use it on a very long term use of it. Another medication that is very effective as well is buspirone. Does not have addictive properties as the other three, such as the clonazepam, lorazepam, and the prazolam and the diazepam do. However, and it also is pretty effective on helping to treat anxiety. Again, back to the non-FDA approved is the venlafaxine Effexor, that is also used as well, and it's used in children as young as 6 years old, and also used in adolescents as well. Just the dosage is a little bit different. Other medicine that is used to help decrease anxiety is hydroxyzine, about 50 to 100 milligram. Sometimes can be used every 6 hours, and that has helped shown to decrease some anxiety as well. It is used a lot to help also because it has some drowsiness properties to it, or sedative properties to it. So it is used as well sometimes to help people sleep. But other medications that are used to help with sleep, and also help with anxiety that are not FDA approved for that are the imipramine, trazodone, Remeron, bupropion, pregabalin, quetiapine, vortioxetine. Those were not designed to be used for that. But Valium was approved by the FDA. And again, start slow, go low, and make sure that you share with the patient that it's only going to be temporary. Hydroxyzine can be used in children as young as 6 years old, and again, start low. It goes as low as 10 milligram, and can be started and can really help decrease some anxiety. But make sure you share that it has sedative properties to it, so it can also make them feel sleepy. Other alternative medicine that can be used to help with anxiety are diet, herbs, vitamin, massages, chiropractic, yoga, meditating, spirituality, traditional Chinese medicine, Reiki. There's so many different things that people can find, alternative medical, that can help them to relieve some of the anxiety as well and help to decrease those symptoms. However, if the symptoms are becoming so severe that they're interfering with their work and interfering with school, then sometimes medication may be needed to help to manage that, and alongside with the alternative medicine and alongside with psychotherapy. Sometimes you'll find that some providers will use augmentation using these medications. They're not FDA approved for anxiety treatment. However, once a patient have used so many different SSRI or so many different SNRI, sometimes they will use these medicines to kind of help augment them and kind of help to decrease some of the anxiety that the patient may be experiencing. Uh, Also, there has been research done with interpersonal psychotherapy and motivational interviewing, and it's not a lot of positive result has been shown, but sometime in combination, some patients say they do well with it, and so therefore I always encourage whatever therapy that will help the person to relieve or feel better with their anxiety as well, but the small research that were done, again, a limited number, have not shown much evidence of positive result. Exercise has been shown to be beneficial for mood and anxiety as well. However, there aren't too many research done for generalized anxiety, so it's again very small number. But patients have reported themselves how much better they feel when they do exercise. Patient and family education for anxiety. Want to do psychopharmacology and psychotherapy. Always want to tell them that the two together are the most effective treatment using cognitive behavior treatment. Uh, Education on potential sequelae from trauma, safe environment to discuss trauma, and then provide them resources. There are so many different resources that they can go and read about and get more information on how they are experiencing their anxiety or depression, so that that can help them to have a greater understanding of what they are experiencing. Health promotion, again, make an effort to buffer the effects of stress and exposure to traumatic events. Always want to share that. Again, good physical health, making sure that you get your physicals every year, see the dentist. All of those things can help potentially eating a nutritious meal, healthy weight and exercise routine, healthy sleep hygiene, stress management techniques to kind of help minimize the risk of experiencing anxiety or depression. So differential diagnosis, again, we talked about the patient coming in experiencing chest tightness or chest pain sometime. Always want to rule out cardiac arrhythmia or angina. Sometimes they say they have shortness of breath, so you want to make sure you rule out respiratory, such as asthma, COPD, or pulmonary emboli. Sometimes it's endocrine. Always want to check to make sure that they don't have either hyper or hypothyroidism as well. And sometimes just to kind of make sure that there aren't any side effects to the already medication that they are taking, and that's what they're experiencing. And if there's any substance use, such as caffeine, cocaine, cannabis, steroids, nicotine, and others that could also potentially be causing anxiety or depression as well. Again, medication as well. Make sure that if always check, make sure is the patient taking albuterol or theophylline or taking thyroid hormones that could potentially also make them have these symptoms that they are experiencing. So major categories of medical condition that mimic psychological conditions. One way to help remember it is to think of the mnemonic think med. So these are the conditions that again will mimic psychological condition. Tumors. H is for hormone, I is for infection, N is for nutrition, and C is for central nervous system. M is for like anything pertaining to like miscellaneous, like sleep apnea, anemia, congestive heart failure. And E is for electrolyte imbalance, like someone having hypercalcemia or having hyperphosphatemia or hypernatremia could also potentially show up with psychological condition. And of course, drug use, including nicotine, caffeine, or prescribed medication, illicit, and alcohol. So just wanted to talk a little bit more about the differences between worry and anxiety. So everyone tends to experience worry in our heads and anxiety in our bodies. So worry tends to be more focused on thoughts in your heads, while anxiety is more visceral and that we feel it throughout our bodies. Worry tends to be specific, while anxiety is more diffuse. We worry about getting to the airport on time. It's just a specific thing, but we feel anxious about traveling, more like a vague, more generalized concern. So you worry about worry is verbally focusing, while anxiety includes verbal thoughts and mental images. This difference is very important as emotional mental images such as associated with anxiety provoke a much greater cardiovascular response than emotional verbal thoughts such as those associated with worrying. So this is another reason why we experience anxiety throughout the body. Worry often trigger problem solving, but anxiety does not. Worry can lead us to think about solutions and strategies for dealing with a given situation, whereas anxiety is more like a hamster wheel and spinning us around, and it doesn't lead to anything productive or productive solution. And it kind of and anxiety tend to diffuse the nature and is less amenable to like problem solving. So kind of need to know this difference so that way when the patient's talking about their feeling a lot of worrying, so you can differ between worrying and differ between anxiety. Another symptoms that may experience again is ADHD that you may see quite a bit of it. I did not touch on it too much, but I do want to talk about that as well because that's something that potentially could come in primary care, especially with children and also adults now, because a lot of adults were underdiagnosed or not diagnosed as children and now are experiencing these symptoms. And sometimes these symptoms can be confused with anxiety symptoms because they kind of share some of the same um, symptoms, such as the poor concentration, such as the poor sleep onset, excessive response to situations. But it changes when the patients start to have inattention versus the worry that I experience and anxiety. Or an anxiety, people experience fear, whereas ADHD is more disorganization. And so the fears come in because they're disorganized and having trouble staying organized. Uh, when anxiety, people tend to have restlessness, whereas ADHD, they tend to have carelessness. Where in anxiety, people tend to experience muscle tension, headache, stomach aches. ADHD, you tend to have more forgetfulness. Anxiety, people tend to overthink. And ADHD is a lot of avoidance of using mental effort, and even procrastination is the word. But they both can again experience irritability. So therefore, really listen to what the patients are saying and ask the right questions in order to kind of make the differentiation, because you could potentially be treating somebody for anxiety and all along what they were experiencing was ADHD. Panic disorders. So the definition of panic disorder. So panic disorder is a discrete period of intense fear or discomfort in which four or more of the following symptoms develop abruptly and reach a peak within 10 minutes. So the key words are that they abruptly happen, and sometimes they happen really fast. It's like going to 0 to 100 within minutes. And the symptoms that you'll hear the patients say they're experiencing are heart pounding, palpitation, like a heart racing you hear. They say that they were sweating profusely sometime, or hands are sweating. Sometimes some people have shaking or trembling. Some people complain of shortness of breath. feeling of choking, chest pain or discomfort. Sometimes they have nausea, abdominal pain or distress. Sometimes they have feeling dizzy, unsteady on their feet, almost lightheaded and want to faint. And some people almost like a derealization that happened, like almost feeling unreality, or should I say a depersonalization, almost feeling detached from themselves, like it's occurring without them. And they're watching this happening to them. A fear of losing control, or AKA going crazy. Fear of dying. Sometimes it's numbness or tingling sensation. Some people feel chills. Some people feel hot flashes. But the key thing is that the symptoms come abruptly, and they usually start to really get intense within 10 minutes. So there are some very distinctive differences between panic disorder and anxiety disorder. Though they share quite a bit of the same of the same symptoms, but there are some key distinct. With panic disorder, you'll kind of hear a sensation of smothering. Patients feel like they are choking. Sometimes they're having chest pain. Sometimes they have fear of dying, or feeling detached or feeling disconnected from the world. Whereas anxiety, there's a lot of complaint of restlessness, feeling edge, feeling fatigue, difficulty concentrating, irritability, mind going blank, muscle tension, sleep problem, worrying, and feeling nervous. Um, so the but they have almost similar symptom, as you can see in the middle, that they're both can experience. People that are having panic disorders and also having anxiety disorder can experience dizziness, nausea, vomiting, that pounding heart, palpitation type of feeling. Some people have the shortness of breath. So you really have to ask the questions to hear what the patient is experiencing in order to kind of differentiate between a panic and anxiety disorder. Treatment for panic disorder. Once the patient meet the criteria for panic disorder, then you always want to check, make sure there's not any current alcohol or substance abuse. If that's so, then you want to send them to offer them a detoxification program. If it is not, then you want to kind of talk to the patient and consider, we tell them to consider therapy. Also, again, using the benzodiazepine to kind of help release some of the symptoms. Sometime also in the long term, using antidepressants to kind of, or using therapy, psychotherapy, CBT specifically, to kind of help minimize some of those symptoms. And of course, reassessing sometime in 2, sometime 4, 10 weeks to just make sure that the effectiveness of the treatment is working out for them. And making sure, is the patient panic free? If so, then you continue with the antidepressant and using the psychotherapy with the CBT, also using the benzodiazepine. But if they are not, they continue to experience panic, then you want to add additional treatment. Maybe making some changes on the medication, using different type of therapy that can help as well. And so the most, again, effective is a combination between psychotherapy and using the medication. Another type of anxiety derived is obsessive compulsive disorder. So the definition of obsessive compulsive disorder is a recurrent and persistent, whether it be thoughts or urges or images. And I know most people are experience, think of the, going and checking the door, but it's the repetitive and the persistent that the reoccurrence and the persistent of it is what makes it obsessive. And sometimes it's a thought. Some people have thoughts and they keep having the reoccurrent thoughts over again about it, and it's very intrusive. It's always unwanted, and this can cause very really high anxiety and distress to that individual. uh, Again, compulsions is defined as repetitive behavior that the person feels driven to perform in response to that obsession. So if a person thinking that they need to close the door and multiple time and we check again, that thought is in their mind, so they feel the need to perform it. Some people it's hand washing, they feel the need to wash their hands all the time. Some people it's a reoccurring thoughts that they have. The thoughts keep coming back and coming again. So it's again, it, it's aiming at preventing or reducing their distress. However, it becomes repetitive over and over and sometimes can cause. So, but with good insight and the individual recognizing that they have OCD symptoms, there is treatment that can help. And then you can kind of help them to know that, how to help them to understand what they are experiencing. Um, So what they call the OCD cycle. So the OCD cycle is obsession, and then you go into anxiety, then compulsion, and then relief, and then back to again the obsession thoughts come in, then the anxiety comes about it, then you have to perform that activity, and then you feel some kind of temporary relief until again that same thoughts come back again. And mostly patients with OCD kind of go through that cycle over and over, sometimes multiple times during their day. So again, asking the questions, how often are you experiencing this? Is it happening? And then we have the subtype of OCD as well, which are related to this idea of cleaning, obsession with cleaning. Some people have hoarding, where they tend to have so many things and they just keep buying or keep obtaining so many different articles, whether it be shoes or bags or just different things, kind of just have them because it causes them a relief for them to have that. So the thought come in, oh, I see this lamp on the street that it says free. I'm gonna bring it, I'm gonna use it. And then they bring it to the house, and of course they don't use it, they don't fix it, but it relieves that anxiety that they had at the time until they perform that activity, which is taking that lamp home. So pay attention to what the patients are saying, you will hear more. Again, some people have obsession with ordering, making sure that things are lined up in the right exact way, meaning that all the shirts have to be facing the same way, all the shirts have to be the same color, that are, if all the shirts are blue, they need to be all blue together. Some people have that with different things, where all the glasses need to be together in one side, and this cannot touch this. So when you ask more questions, they'll tell you more about what the compulsion can be and what the obsessive thought is. And some people have they have the obsession and it's not visible. So it's not something that they actually do. It's just in their mind that they're constantly doing numbers or constantly looking, and their mind is going over and over. And then there is what they call harm obsession, where the person is checking all the time, thinking, this fear comes. That they need to check and make sure the oven is off, make sure the doors are locked, make sure that the keys are not in the engine, and they go back and forth and back again multiple times until that anxiety is relieved. Causes of OCD, there is genetics, it is environmental, and some people's and research have shown that it's a brain structure and the function as well. Clinical management, well, depends on how mild or moderate or severe. When it's mild or moderate, typically, especially for mild, it can be treated with cognitive behavior therapy. But when it's moderate, sometimes you may need to have both cognitive behavior therapy and also using an SSRI to kind of help relieve that symptom that they are experiencing. But when it is severe, sometimes it may need actual a psychiatric evaluation, and of course using the SSRIs with or without the psychotherapy CBT as well, to kind of help them to understand. And again, when there's sometimes you will see that there's make a lot of improvement. What I've seen is that when the patient is aware of their diagnosis and they have a little bit more awareness of their obsession, they tend to do better. So recognizing their obsession and be able to seek the treatment and follow through with the treatment really can show a lot of improvement. Social anxiety, another common anxiety that you will see in primary care. is the risk factors for that are usually parenting style, early traumatic event, brain structure, observing others with sad, isolated upbringing, genetics, and societal expectation. Social anxiety, again, it's kind of back again to a little bit of a cycle. You start to worry, you have worrying thoughts, negative expectation, high distress. Then it goes to contribute to the avoidance and use of safety behavior, like you avoid eye contact, you keep your hood on, you put earphones on, don't really want to talk to anybody and kind of isolate a little bit. Then it's making negative first impression with peers as well. Most people are prone to do that. um, so peers think students, like, especially for a young adult or adolescents, you will see that they think that, oh, people are not really interested in me. They don't think I'm friendly. People are not friendly. And then it leads to this continuous negative interaction with peers because they think that, I'm the loner, and, they don't really make effort, and they continue to isolate more because, again, that social anxiety really makes it hard to interact with others. Another type of anxiety, it's that post-traumatic stress disorder that also a lot of people experience. So PTSD is defined on the DSM-5 as direct exposure. So you have to experience those direct exposure to a trauma or event, witnessing the trauma or event, or indirectly by learning from someone, a close friend or relative, about that trauma or event, or repeated or extreme exposure in the course of a professional job, not necessarily through media. The thoughts are very intrusive, they are recurrent. Some people experience traumatic nightmares, flashbacks. Sometimes it's in very intense and prolonged distress. Um, and some people experience trauma-related thoughts. Some people, there are a lot of triggers from external reminders. Some people have the inability to recall um, key features of the trauma. Sometimes they have negative belief, distorted blame, persistent negative trauma-related emotions, feeling alienated, detachment, estrangement, constricted affect. And so you have to have at least one, one from stressor, one from the intrusion symptoms, and then you need at least one of the persistent effort avoidance, and then two of the negative cognition, and two of the alteration in arousal and reactivity in order for you to be diagnosed with PTSD. Risk factors of PTSD, I said it before, is either observing or experiencing terrorism, natural disasters, car accident, and definitely abuse, whether it be physical, emotional, sexual abuse. Those definitely can sometimes cause PTSD. Clinical manifestation, again, that individual continue to experience and re-experience the traumatic experience over and over, as if it was happening the same time when it had happened before. Sometimes the symptoms are very extreme arousal. Sometimes they have avoidance of associated stimuli or numbing or generalized response. Sometimes, if it's a car accident, a person will completely avoid driving in order to avoid that experience of when this traumatic event that they had. So when someone has PTSD, one of the way that it manifests itself is sometimes people have avoidance and numbing, which can lead to avoid discussing events. They have emotional numbness. Sometimes they have adverse activities done in the past. They just stop doing them. Some people experience intrusive memories, so they have flashback and very disturbing dreams or nightmares. some people experience them anxiety and emotion. So it's anger and irritability, guilt, shame. Some people turn to substance abuse or destructive behavior, and they sometimes can be very easily startled. In extreme cases, we've had individuals commit suicide and also become very violent. So this is a chart on acute stress disorder and PTSD. As you can see, acute stress disorder, the difference between acute stress disorder and PTSD is that acute stress disorder only lasts about a month, whereas PTSD tend to last, acute PTSD lasts less than 3 months, and then PTSD then lasts more than 3 months. So the way it will happen is the distress or the traumatic event occur, and in less than 1 month, we call it acute stress disorder. Then, if it's lasting more than 3 months, then it become acute PTSD. Then, if it lasts more than 3 months, then it become chronic PTSD. So management of PTSD. So treatment for PTSD sometimes is 3 to 6 months and sometimes longer. If And also there may be other disorders that could potentially be occurring at the same time. So again, therapy is one of the mainstay. Doing family therapy, involving the family to understand what that individual is experiencing or that patient is experiencing. Cognitive therapy for that individual themselves. Exposure therapy, EMDR therapy, group therapy, and of course, medication can sometimes help to minimize some of the symptoms for anxiety or even depression that could also be a comorbid to this. So these are the pharmacotherapy treatment for PTSD. Again, the SSRIs to kind of help to minimize the symptoms of anxiety and depression, TCAs, MAOIs as well, the SNRIs, and sometimes we have to use the atypical psychotics like risperidone, olanzapine to kind of help also to help minimize some of those symptoms. Clinical presentation and physical exam. Patient um, present for treatment in primary care, or they usually present in the ED with feelings of worry or anxiety or fear. Sometimes they have physical complaints where they talk about, oh, I'm feeling tired all the time, I'm irritable, and they have cognitive changes, having trouble sleeping. Sometimes it may be associated again with other mental health disorders such as depression or substance use disorder. Generalized anxiety, again, is excessive anxiety, worrying about the event or activities. And then some people even experience panic disorder, which is characterized as which can happen recurrently with someone that is experiencing PTSD. Diagnostic, again, meeting the criteria from the DSM-5 that we went over earlier. Again, always complete a physical exam to rule out any physiological reason. And then the ROS, doing a routine blood work, obtaining a CBC, a CAM7, CSH, B12, the same labs that I listed earlier again. Definitely obtaining a urine toxicology just to make sure there's no any substance or any illicit drug use that could potentially also be the trigger or the reason for the symptoms that the individual is experiencing. Differential diagnosis and management. Again, always think about possible interference with medication, other organic condition that can mimic symptoms of anxiety. Also, always think of the patient who do not respond to first-line medication regimen, refer them to a mental health specialist. If the person is thinking about harming themselves, then refer them to the ED so that they can get the help that they need. And using medication, your antidepressant, your benzos, the buspirone, the atypical and antipsychotics, and the psychotherapy, all of these can help the patient to help minimize some of the symptoms and help to get them the treatment that they need to help alleviate some of the symptoms. Substance abuse disorder. In the United States, illicit drugs are often associated with substance abuse. However, alcohol, nicotine, prescription painkillers are among the most widely abused substances. Substance abuse is underdiagnosed in primary care, so we need to be vigilant as to what is going on when a patient presents themselves. And there's always sometimes experience dependence or withdrawal, or sometimes they experience have tolerance to the medication or the substance that they are using. Specific substances, alcohol, um, barbiturates, benzodiazepine, as I mentioned earlier, opioids, compounds similar to barbiturates or benzodiazepine that can also be abused potentially. Central nervous stimulants are the cocaine, hydrochlorides, the amphetamines, or the amphetamines-like stimulants. Some people also can abuse psychotomimetic and hallucinogens, just like PCP and LSD, the inhalants, your anabolic steroids, and your injection drug use. So the substance use behaviors that you will see is that in order for the person to receive a substance use diagnosis, they need to have substance use leading to significant impairment or distress. And at least two of those symptoms listed below must be in there for at least within the last 12 months. So any persistent desire on successful efforts to cut down, any great deal of time spent in the activity necessary to obtain the substance, um, any craving or strong desire or urge to use the substance, where current use resulting in a failure to fulfill major role or obligation to work, meaning that they rather miss work or school or be at home in order to obtain the substance. Continued use despite having persistent or recurrent social or interpersonal problem caused by or exacerbated by its effect. Important social, occupational, recreational activities are given up or reduced because of the use. Again, we are currently using situation in which it is physically hazardous for them. Um, use They use it despite knowledge or having persistent or recurrent physical or physiological problem that is likely to have caused exacerbated by the substance. Tolerance and of course withdrawal. Indicators are there are behavior problems that appear first. Patient may present with psychological, physiological, physical and behavioral signs of addiction, or it may have been witnessed by a friend or family member that may come into you to say, oh, I noticed that my child or my husband or my friend has been, having this behavior. Sometimes patients come to you and request assistance with their addiction. Sometimes it's family members that express concern. And sometimes it's that they are found intoxicated or have intoxicating related injuries and are brought into the hospital, and then they need to have follow-up in order to obtain it. Um, Always want to make sure that there aren't any respiratory complication with smoking, liver complication, alcohol, infectious disease from the injection of drug use. These are the criteria. Another wonderful mnemonic again, chew that cup, to kind of help you to know of someone having a substance use disorder. Craving to use the substance. This is how you know can pick out who's using more. The person wanting to cut down or stop, but not managing to taking the substance in a larger amount than it was prescribed, or were no longer meant to be taken, neglecting other part of their life because of the substance, continuing use when it causes problem in relationship, using substance even when it puts them in danger and put others in danger as well. So diagnostic criteria, again, chew that cup, cut down, health, excessive use, withdrawal, time, hazardous use, activities, tolerance, craving, obligations, personal problems. Another way to screen as well is screening using the 5 A's, ask, advise. So first, let's go back to ask. Ask, you screen for substance use and assess several levels. Advise, using not a non-judgmental approach. You want to express concern to the patient and also let them know the level of the risk, that the medical risk that there is associated to the medication, to the substance that they are abusing, pardon. Assess, always want to evaluate the patient's stage of change or willingness to or readiness to change, and also encourage continued reflection of their health concern, and then provide them with the opportunity to discuss the pros and cons of the use and barriers of discontinuing this substance. Assist, express concern, curiosity, and empathy. Always be ready, if ready, to reduce or stop use. Engage the patient on giving them steps to achieve those goals. Always help them to, the management of the substance. Uh, and the person is sincerely wanting to really quit, make sure you build rapport enough for them to understand that the therapeutic way, for them to be able to easy to talk to you about it, and you can then help them to receive the right help that they need. Arrange by following up. Number one, also making referrals. Sometimes it may be pharmacotherapy by prescribing something to kind of help relieve some of the withdrawal. And definitely refer to an addiction counseling or specialist to kind of help them. There is Alcohol Anonymous, there's Narcotic Anonymous, or there is Smart Recovery, peer recovery groups. All of those things can be arranged for the patient to follow up with. Substance abuse screening tools. We use CAGE questionnaire to kind of help with, which stand for cutting down annoyance by criticism, guilty feeling, or eye openers. Then there's the T-H questionnaire that also stand for tolerance, annoyed, cut down, eye opener as well. The CRAFT questionnaire that is used, also that the craft is for car, relax, alone, forget, friends, and trouble. So those are the questionnaires. The one that you'll see mostly is in primary care is CAGE questionnaire. So another screening tool that is used for alcohol is the audit. The craft is used for the adolescents. Cage again used for adult, and the T-ACE is used as well. For opioid, there is the opioid risk tool. There is the SOAP, which is the screening for opioid assessment for patient with pain. And then there is the prescription drug monitoring program that you can actually see as well, how often a patient is getting their prescription, and if they are using several different providers to get that same prescription as well. This kind of help to give you a bit of what is going on with that patient. Diagnostics, laboratory tests should be tailored to that individual. Drug screening, of course, checking liver enzyme, renal function, hepatitis panel, especially if there are drug use, IV drug use or needles, HIV screening, checking for pregnancy, and always checking for the thyroid as well. The VA and the DoD have in place clinical practice guidelines on how to support uh, the individuals that may be experiencing substance use disorder. They have psychotherapy, cognitive behavioral harm reduction, outpatient program, or long-term residence for rehab programs as well. Then, you have to learn when it's indicated for them to receive a referral for pain management specialists, pharmacotherapy, again, based on which substance that the person is addicted to, antidepressant, is they're experiencing depression, and any antagonist to kind of reverse for an adversive drug, and support group, and also making sure the patient have coping skills education as well. treatment of withdrawal. For alcohol, the CY is used. Um, it stands for Clinical Institute Withdrawal Assessment Alcohol Scale. That gives us a number that will generate how the treatment will go, depending on whether it's uncomplicated, severe. And the benzodiazepine, lorazepam, diazepam, and chlordiazepoxide, excuse me. Thiamine is used as well for moderate to severe and to help prevent neurologic symptoms. And for complicated, patients are usually inpatient in order to receive treatment. For opioid withdrawal, there are two mainstays that are used right now. Buprenorphine is used and methadone is used. Patients can experience withdrawal seizure, which may occur from the benzodiazepine or alcohol withdrawal. Sometimes some patients experience delirium tremors, which can occur again with severe alcohol withdrawal. And patients sometimes have severe tachycardia, tremor, confusion, they have hallucination and agitation. And these symptoms can occur 72 to 96 hours after they have the last consumption. Overdose, depending on which substance is ingested. Again, the treatment is a little bit different based on what it is. If it's an opioid overdose, it requires prompt delivery of naloxone and preferably a period of medically supervision after that. And any ingestion of any substance that result in unstable vital sign warrants emergency room or referral for stabilization. Again, suicidability or homicidability, psychosis, all those may warrant, again, going to the emergency room and being hospitalized. Readiness for treatment is something that needs to be also assessed because not everybody is ready for treatment, but any patient who actively requests treatment for moderate or severe substance use disorder should be referred immediately to a facility that can provide them support. Schizophrenia. The DSM-5 criteria to meet for schizophrenia is a chronic, severe, disabling brain disorder. It is the most common subtype. There are the most common subtype of schizophrenia are paranoid schizophrenia, characterized by one or more delusions and frequent auditory hallucination and may be persecutory. Other type is dementia, brief psychotic disorder, uh, schizophreniform and schizoaffective disorders, delusional disorders, and substance-induced psychotic disorders. Clinical presentation. Again, there's that prodromal period lasting about 50, sometime plus week before the psychotic presentation of the schizophrenic illness. It's the people when you experience some people experience changes in their grades, sleep, mood, with particular complaints of anergia and reduced concentration, attention, drive, and motivation. Some people experience hallucination. Not some people, excuse me. People experience hallucinations, delusion, twitching, moving back and forth, responding to questions with answers that do not make sense, acting in ways inappropriate for the situation, and sometimes they have poor hygiene as well. Differential diagnosis. Always want to rule out any alcohol-related psychosis, bipolar affective disorder, cocaine-related psychiatric disorder, delusional disorder, depression, mental disorder secondary to general medical condition, and schizoaffective disorder. Clinical management, it's usually mainstay, it's antipsychotic, definitely counseling, using cognitive behavior therapy as well. Patient and family education, medication usage, avoid alcohol use, healthy lifestyle habits, stress management, sleep hygiene, and follow-up care is also needed. And most importantly, reminding the patient and the family of adherence to the medication and making sure that they're taking it every single day. resources for mental health screenings. These are the references. And if you guys have any questions, we'll be meeting back again with you to answer any questions that you may have. Looking forward to seeing everyone. Have a wonderful day.